Welcome to MRI Knee Made Easy series. In this video, I will be showing some of the interesting cases of MRI knee. So the first case is a 22-year-old male who presented with pain in the knee joint for 1 month, and he's also having fever and leukocytosis. So let's see. This is the sagittal PD fat set, and we can see that the tibia is showing presence of a large collection in the intramedullary location, which is showing increased signal intensity on PD fat set, plus there is evidence of adjacent marrow edema. Let's see the axial sequence. We can see this is the collection which is located inside the tibia, and there are presence of multiple areas of cortical breach. So there are presence of multiple areas of cortical breach, and there is overlying subcutaneous edema, and the collection is leaking into the overlying soft tissue, as we can see here. And there is also presence of collection, extension of this area of inflammation in the infrapatellar half of fat pad. So there is an intraosseous abscess with cortical breach, extension into the subcutaneous and overlying soft tissue areas, and there is intra-articular extension in the half of fat pad. Let's see other sequences. This is the sagittal T2 weighted sequence, and in this we can see that the area of abnormality is not very hyper intense like fluid. So it is intermediate in signal intensity on T2 weighted sequence. This is the thin cut PD fat set sequence, tube sequence, and this is also showing area of altered signal intensity, the collection within the tibia with multiple areas of cortical breach. You can see there are multiple areas of cortical breach here. This is the sagittal GRE sequence, thin cuts, and the collection is appearing hyper intense on this sequence. These are the two T1 weighted sequence, one pre and another one is the post contrast sequence. This one is the pre-contrast sequence and this is the post-contrast sequence, and we can see there is thin peripheral enhancement surrounding the abscess cavity. So the granulation tissue surrounding the abscess is showing enhancement. We also have a diffusion weighted sequence for this patient. So on diffusion weighted sequence, the abscess cavity is showing restriction of diffusion, and this is the ADC which is showing corresponding defect, hypointensity, so it is showing diffusion restriction. So this is a case of osteomyelitis involving tibia with formation of intraosseous abscess, and this intraosseous abscess is extending into the joint. There is intra-articular extension with involvement of half a fat pad, and there are multiple areas of cortical breach with extension into the overlying soft tissue. Rest of these structures, the knee joint are normal, cruciate ligament and menisci, these are all normal. Let's move to the next case. This is the case of 55-year-old female who presented with pain in the knee joint for 2 years and followed by sudden increase in the severity of pain for the last 1 month. So this is the sagittal PD fat set. We can see there is mild effusion. Anterior cruciate ligament is showing hyperintensity. However, the fibers appear intact. PCL is normal. This is the medial meniscus. This is showing areas of hyperintensity in the posterior horn, intrasubstance signal intensity, mucoid degeneration, and we can see this is the area of posterior root of medial meniscus, and this is not visualized on the sequence, so this is a ghost meniscus sign, which suggests that there is root tear involving the posterior horn, posterior root of the medial meniscus. This is the lateral meniscus, which is normal. There are multiple areas of cartilage degeneration involving the femur, tibia, and patellar-articular cartilage. And there are presence of multiple marginal osteophytes. Now coming to this area, as this is the MRI of 55-year-old female who is osteoporotic, and so this is an area of osteochondral defect, and the overlying bone is osteonecrotic. It is hypointense on the sequence, and there are multiple areas of cystic changes in the underlying bone. So this is a subchondral insufficiency fracture with formation of osteochondral defect with involvement of the overlying cartilage, and this fragment is unstable as it is outlined by the areas of hyperintensity and cystic degeneration. We can see that in the GRE sequence. So this is the GRE sequence, and let's zoom it, and we can see this fragment of bone is outlined by fluid signal intensity linear line, and there are multiple areas of cystic degeneration in the line. So there are increased chances of getting it detached from this donor site and form a loose body inside the joint cavity. And this osteochondral defect is basically involving the weight bearing part of the knee joint, that is the medial femoral condyle. Let's see the medial meniscus. So this is the coronal PD fat sac, and as we can see, this is the medial meniscus, which is showing horizontal intrasubstance signal intensity, which is extending up to the peripheral surface. So there is horizontal tear, which is most likely degenerative. This is the anterior root, which is normal, and this is the area of posterior root, which is completely torn, and because of this tear of the root attachment, the menisci is slightly extruded outside the joint. So this patient is having changes of osteoarthritis, cartilage degeneration, meniscal root tear with extrusion, and is also showing osteochondral defect with unstable fragment. This is the sagittal T2 weighted sequence, which is showing normal ACL, PCL, and this is the osteochondral injury. Let's move to the next case. This is a case of 36-year-old male who presented with severe trauma in the knee joint, and this is the sagittal PD fat sac sequence. And as we can see, the patella is caudally dislocated, and there is complete rupture of the quadriceps tendon from its patellar attachment site. So there is complete tear of the quadriceps tendon at its patellar attachment site, and because of the unrestricted action of the patellar tendon, the patella is dislocated downwards, and there is extensive collection surrounding this region. We can also see that there is complete tear of the anterior cruciate ligament. Posterior cruciate ligament is showing mild buckling. This is the medial meniscus, which is showing horizontal tear. And this is the lateral meniscus, which is also showing horizontal tear involving the anterior horn. We can see presence of Baker cyst in the posterior aspect of joint in the popliteal region. Let's see that in axial plane. So this is Baker cyst, which is basically distension of the bursa between medial head of gastrocnemius and semimembranosus tendon. And this is the complete extent of the Baker cyst. We can see here this is patella. There is extensive collection in the region of defect, and this is the quadriceps tendon, which has recoiled in the thigh because it is completely detached from its patellar attachment site. This is the sagittal Gre sequence, which is also showing similar findings. This complete rupture of quadriceps tendon, horizontal tear involving both the menisci, complete tear of the anterior cruciate ligament, presence of Baker cyst, and some osteochondral injuries with edema in the underlying bone. Let's see this coronal cube sequence. This is the posterior cruciate ligament. It's normal. Anterior cruciate ligament is not visualized. Menisci are showing horizontal tear. And this is the Baker cyst, which is seen between the tendons of medial head of gastrocnemius and semimembranosus tendon. Let's move to the next case. This is a case of 45-year-old female who presented with trauma in the knee joint, acute trauma. And we can see there is complete tear of the anterior cruciate ligament. There's complete tear of the anterior cruciate ligament. And the posterior cruciate ligament is also torn from its femoral attachment site. So there is complete tear of the anterior cruciate ligament and posterior cruciate ligament. There is mild joint effusion. There is edema in the posteromedial tibial plateau. This is the medial meniscus, which is showing intrasubstance hypersignal intensity in the posterior horn, which may be because of mucoid degeneration. This is the lateral meniscus, which is showing continuous bow tie appearance. So this is a discoid meniscus. We can confirm this in coronal plane. So this is a discoid meniscus. We can take measurement of its width. So it is measuring 18 mm in width. That is partial discoid meniscus. It is partially covering the tibial plateau. And as discoid meniscus are prone to degeneration, this discoid meniscus is showing horizontal signal intensity here in the anterior horn. And there is also presence of a vertical tear involving the inferior leaflet of the anterior horn. Let's see the Gre sequence. We can see a fragment of bone attached with the femoral end of posterior cruciate ligament, which suggests that there is eversion fracture from the femoral attachment site of PCL. ACL is completely torn. This is the medial meniscus, which is showing degenerative changes, and this is the lateral meniscus, which is discoid, and it is showing vertical tear involving the inferior leaflet. It is extending to the inferior articular surface and is involving anterior horn and body junction. Let's see the coronal plane. So we can see this is the bony fragment which has avulsed from the femoral attachment site of posterior cruciate ligament. And there is a small bony fragment which has come out from the femoral attachment site of anterior cruciate ligament. So there is avulsion fracture involving femoral attachment site of ACL as well as PCL. And there is discoid lateral meniscus with complex tear with horizontal as well as vertical component. And there are changes of degenerative joint disease, cartilage degeneration seen at multiple areas in the femur, tibia and patellar articular surface. And there are presence of few osteophytes. This is the sagittal oblique sequence of the same patient, and we can see here this is the anterior cruciate ligament and this is the bony fragment. So this is the end of this video. I hope you have enjoyed the video. Thank you.